Good evening, everyone. I hope you're well and welcome to our webinar, Treatment for Indigestion and Bloating. My name is Morella and I'll be your host for this evening. Our expert presenter for this evening is consultant gastroenterologist, Dr. Hanumanta Varaya. The presentation will be followed by a Q&A session. If you'd like to ask a question during or after the presentation, please do so via the Q&A icon, which is on the bottom of your screen. This can be done with or without giving your name. If you do give your name, we will be able to follow up with your questions after the webinar if we haven't been able to answer your question during the webinar itself. If you would like to book a consultation, we have Chelsea Dan from the private patients team on hand to take any phone calls after the webinar, and we'll provide the telephone number at the end of this session. Please note the webinar is being recorded. I'll hand over now to Dr. Hanumanta Varaya, and you'll hear from me again shortly.
We will briefly discuss about indigestion and its causes, and gastroesophageal reflux, and briefly on bloating and its causes, and finally I would like to touch upon some myths and confusions around the medications such as proton pump inhibitors, which are used to treat indigestion, and also importance of diet in the management of indigestion and bloating. And finally, we will give time to ask questions. So indigestion is a very common symptom, and in my practice, about 40% of the patients I see, either they come with symptoms of indigestion or are bloating. And in fact, about 20% of general population do suffer from these symptoms of indigestion, but approximately about only 5% actually present to their GPs for help. The symptoms are very varied. Sometimes patient might be just having burping and belching and some abdominal pains, but as such, one should have at least 3 months symptoms of upper abdominal pain and fullness after eating and early satiety, and they are the typical symptoms of indigestion. At many times, the symptoms of gallbladder diseases, pancreas, and some motility disorders with the gut itself may overlap with the symptoms of indigestion. Although majority of these patients are benign conditions, but there's no doubt that indigestion and bloating is a cause of psychological distress and poor quality of life. As I said earlier, I think that most of these patients are benign conditions, and you would be surprised to know that cancers are actually identified only in about less than 2% of these patients. And the acid-related symptoms and diseases are seen in about 25% of the patients. That could be ulcers and severe inflammation in the gullet, or Helicobacter pylori induced ulcers. I think approximately about 10% of the patients do suffer from sinister symptoms, which needs urgent investigations. And those symptoms could be someone who has had indigestion for the first time in life after 50 years of age, and if you had lost weight or suffered any difficulty in swallowing or vomiting, I think those are the symptoms I think you should consult your GP or perhaps come out to us for investigations. Now, this is the group of patients we would really would like to help, and you have had your endoscopy, but that was negative. But what to do further? And you still having symptoms, and we would like to really help this group of patients. Although most of these patients are functional in nature, but there are some other diseases could be causing the similar symptoms, like indigestion symptoms, such as motility disorders and gallbladder issues, and perhaps celiac disease. I think interestingly, I would like to really see in two ways these group of patients who had normal endoscopy still having symptoms and associated with some sinister symptoms. And there is a clear evidence that approximately about 6 to 7% of these patients might be having some other cancers, cancers of the pancreas, gallbladder, or perhaps lymph node cancer. I think those patients really need further thorough investigations to rule out any cancers in those patients. And other group of patients, they might be still having symptoms of gallbladder disease, and they certainly would like to know what's causing the symptoms, and if possible, they want to get treated and get on with their life. If you have a mild symptoms, perhaps your GP might just do a test for Helicobacter pylori and treat you with antibiotics if you're positive, and that might resolve your symptoms. Or it might just simply give you some empirical treatment with acid suppression for about 2 to 3 weeks, and your symptoms might disappear if you had any small ulcer or inflammation in the gullet. But it might also send you for an endoscopy as well. But I think if you have a severe or any sinister symptom, I think you should really seek early help because picking up any cancers at an early stage has a better prognosis. Most of the indigestion patients are actually suffering from functional dyspepsia. This is very common in patients who've got anxiety and depression. And it might be that there is a disordered gut-brain axis, the cause of their symptoms. They're often quite difficult to treat, these patients. But in my practice, what I've seen is that meticulous dietary modifications and would certainly help, and also treating them with neuromodulators to calm down their gut-brain axis, such as antidepressant, would certainly help these patients. Now, the gastroesophageal reflux, reflux is a very common thing, and it's often quite physiological. And but if you're really getting more frequently and more often during the nighttime, and that is probably is what is called as a gastroesophageal reflux disorder, and you might be having a very typical symptoms of heartburn and regurgitation, and others might be having atypical symptoms such as wheeze and some dry cough and hoarseness of voice. Majority of this mild gastroesophageal reflux could be treated with a course of acid suppression medications. However, there are a group of patients who would be having very refractory symptoms of gastroesophageal reflux. And the reason in them could be due to insufficient acid suppression. There's only about 25% of the patients would actually get rid of their symptoms by once daily acid suppression medications. Maybe that we need to optimize their treatment, increasing the medications to twice daily maximum doses to treat their symptoms. And there are also other conditions could be the cause of their refractory gastroesophageal reflux. And sometimes we see a lot of younger patients, allergic individuals, presenting to us similar symptoms like gastroesophageal reflux, but they might be having inflammation in the gullet due to allergy mediated, not acid related. Those patients typically need endoscopy and biopsies from the gullet to confirm this disease. And as I said earlier, I think there could be other causes such as motility disorders of the gullet, or motility disorders of stomach could be causing their refractory symptoms. I would say that everyone who has got worrisome reflux benefit from having a gastroscopy. The reason behind that is that if we know what we are dealing with, we could actually plan your management better. For example, if you have a Barrett's esophagus, you probably need your acid suppression medications for a lifetime. Whereas if you have no structural damage, inflammation, or ulcers, perhaps just take a short duration of acid suppression medications with the lowest dose possible. I think that most of the mild symptoms of gastroesophageal reflux could be treated just by lifestyle modifications and perhaps taking medications as and when required. Some of the lifestyle modifications, such as elevating the iodine of the bed and avoiding some of the foods which cause relaxation of the lower esophageal sphincter, would be useful, such as spicy food, chocolate, and fizzy drinks. Obviously, there's smoking and heavy alcohol also implicated in the relaxation of the lower esophageal sphincter, and avoiding these smoking and alcohol would certainly help them as well. But if you have severe symptoms, I think you should see us, and we can investigate you thoroughly to look for any damage to the gullet, and also to pick up any other causes of symptoms mimicking like gastroesophageal reflux. And of course, severe and refractory symptoms of gastroesophageal reflux, there are surgical interventions and also endoscopic treatments are available. Now, I have to say that the proton pump inhibitors, what we call it as lansoprazole or omeprazole, and these medications are there for the last 30, 40 years. And ever since I qualified, and I've seen these medications are wonderful drugs which saved lots of lives. And in the past, when a patient presented with severe bleeding or ulcerations in the stomach, they would straight go to the surgery. But nowadays, we can successfully treat these patients with proton pump inhibitors. And to be very effective, these medications has to be taken 30 minutes to 1 hour before the first meal of the day. And the reason is that the proton pumps which secrete the acid are maximally expressed when you're in an empty stomach. And the acid suppression medications are more helpful to block these pumps and decrease the acid secretion. And there are some safety concerns with the long-term usage of proton pump inhibitors. And some side effects such as infections, Clostridium difficile and Salmonella are quite common in these patients. And some other malabsorption of magnesium and calcium and iron is also seen in patients. There are some concerns about long-term use of these medications recently, whether or not they are associated with kidney disease. I think that most of them are more case reports, and but very controversial. They probably need more robust studies to confirm this, and also dementia as well. Patients, studies conducted so far, 2 studies, they said long-term use of proton pump inhibitors is associated with memory loss, but 2 other studies have rejected this. But the bottom line is that if you need these medications, it is very helpful, and but they are being misused, and they are being prescribed for unindicated diseases. I think that should stop. At Benenden Hospital, we have a very dedicated endoscopy unit, and we can offer you comprehensive gastrus endoscopies, surveillance, and taking biopsies and H. pylori tests. And we can also thoroughly investigate you with all the radiological investigations. And there's also 24-hour pH monitoring to confirm the acid reflux available here as well. And some of the tests are not available here, but we could certainly outsource these tests to the nearby hospitals. And if further treatments required for your refractory gastroesophageal, we can put you in the right hands to get treated. Also want to tell you that surgical interventions such as laparoscopic fundoplication is also available here at Benenden Hospital. Bloating is again quite common symptoms, which is probably up to 30% of the general population suffer from bloating, and it's more common in patients with functional diseases such as IBS and functional constipation. Patient typically present with increased pressure, fullness, and symptoms of gas trapping. It is not known why and how one would get the symptoms of bloating. It is quite a complex pathology. However, some reasons such as increased gas production due to complex and digestible carbohydrates in the gut could be the cause. And I think there's a lot of evidence coming out that change in the gut microbiome could well be the cause of some of the functional gut symptoms such as bloating and indigestion, and somewhat very common in patients with stress and anxiety as well. There's certainly some organic causes which causes bloating as well, such as celiac disease and some pancreatic enzyme deficiencies, and small intestinal bacterial overgrowth. Very rarely, some cancers could be causing obstruction and gas trapping as well. And it's quite common in patients who underwent previous fundoplication and other surgical procedures. Certainly, we would like to investigate for all these organic causes and treatable causes to help you with. So, when to see a doctor when you have bloating? If you have diarrhea, bloody stools, and pale greasy stools, that could be due to some malabsorption, such as celiac disease or pancreatic enzyme insufficiency, I think you certainly need to see your doctors. And if you're experiencing severe abdominal pains and uninterrupted weight loss of more than 5%, you should really see the doctors. And the treatment is mainly very much individualized. If you have any severe symptoms, then we would like to investigate you thoroughly to rule out any treatable causes or any rare cancers. And if your symptoms are predominantly due to diet-induced, I think you would probably benefit from dietary intervention, such as a low-FODMAP diet, and perhaps taking some probiotic to regenerate good bacteria in your gut. And if your symptoms of bloating are predominantly due to psychological issues, you might benefit from some neuromodulator medications and some behavioral therapy as well. So at Benenden Hospital, we could certainly investigate you for all the treatable organic causes. And also we can offer a breath test to diagnose any possibility of small intestinal bacterial overgrowth. And we also have a dedicated dietitians who could help you with some exclusion diet and low FODMAP diets. Finally, you may have heard about this low FODMAP diet. This was posed by an Australian researchers more than a decade ago. It's quite popular among the world, and it is quite intense and boring as well. And these are the foods with the high FODMAPs that you should be really avoiding. And I've listed here some foods which would help you. These are a low FODMAP diet. Obviously, I think we would not recommend our patients to practice low FODMAP diet on their own. There is an increasing chance of fallout from the program because it is quite intense and boring. And also some patients tend to develop some nutritional deficiencies adhering strictly to this. So I would advise that if you're intending to practice low FODMAP diet, I think you should see a dietitian to get help. They can actually advise you on exclusion of the diet and then reintroduction of the FODMAPs, and they can design you a modified low FODMAP diet which suits you better. That's it. Thank you very much.
Many thanks for that. Now we'll take some questions that have been answered, that have been asked, sorry. So if I start with the first one, I'm 34 and suffer quite badly with bloating, particularly after eating. I have tried changing my diet and not drinking fizzy drinks. It is uncomfortable, but not painful. Should I still get this checked?
I think, yes, I would suggest that at least we should do some basic investigations in your case to rule out some malabsorption conditions. And once they are ruled out, and if you don't have any worrying symptoms, I think perhaps you should really see a dietitian for a dedicated dietary modification.
Thank you. Next question. I recently saw my doctor about my regular stomach pain and discomfort after eating. They suggested a gastroscopy, but I am worried about this. Would I be awake for this, and would I need to stay overnight in hospital?
I think it is not a painful procedure, the gastroscopy. And we can give you sedation, and that sedation would not necessarily just knock you out during the procedure, but it will keep you comfortable. The procedure itself, it takes about 10 minutes to do, and most of the patients are, could go home, excuse me, an hour after the procedure, and we don't normally keep the patients in the hospitals after the procedure.
Thank you. Next question. I'm quite an active person and cycle to work most days. My GP suggested exercise can help bloating, but after eating breakfast, I feel so bloated that I don't enjoy cycling. Should I avoid exercise so soon after eating?
I think you should try and take a light exercise, perhaps a casual walk after your dinner or after lunch. And certainly, I wouldn't advise you cycling, which is probably can cause more discomfort in your tummy. And I would be interested to know what kind of investigations you had so far. And occasionally, I think there might be some, as I mentioned earlier, there might be some issues with motility disorders, and it's worth checking to make sure that your gut is actually working well.
Thank you. Next question. I don't suffer bloating pains, but I feel that my tummy rumbles and makes noises so regularly that it can be embarrassing. It even makes noises when I'm not hungry at all. Should I see a gastroenterologist? Sorry, didn't pronounce that correctly.
Again, I think, this is the most of the patients, it is just the perception that, there is the content in their gastrointestinal tract is quite a lot, and they're producing a lot of gas. This is actually just a false perception. But yes, I think there might be the reason that you are probably eating a lot of complex carbohydrates, which is drawing a lot of water into your gut as well. And perhaps I think you would certainly benefit from some dietary modifications such as low FODMAP diet to decrease the osmotic load in your gut.
Thank you. Next question. I struggle to sleep at night due to acid reflux and sometimes wake up because of it. I have stopped drinking tea and sleep more upright. Are there any other solutions I can try?
Well, certainly, I think, as I mentioned in my talk, I think, elevating the edge of the bed at least 6 to 8 inches would help you. And I think you might be having inadequate acid suppression. And I think it would be useful that, if you could, swap your, if you could take an extra acid suppression medication an hour before your evening meal, certainly would help some of the patients.
Thank you. Next question. I suffer quite badly with heartburn and bloating after eating. I have tried changing my diet. Are there any natural remedies I can try before resorting to an endoscopy?
I think we have advised patients to take peppermint capsules, which are quite good. And some patients would benefit from charcoal tablets as well. And I think there's a lot of information on the National Natural website, medicines website as well. You could have a look at that.
Thank you. Next question. What does modulation of brain-gut axis mean?
Now, I think that's a good question. And basically, like any part of our body, our gut is heavily innervated with the nerve endings. And in some patients, especially patients who are very anxious, these nerve endings get quite irritated. And this is sensed very easily by our gut and our brain as well. And so modulating this, what we call as a visceral hypersensitivity or irritation using some of the low-dose antidepressant is clearly shown to be benefit in those patients with a disordered gut-brain axis.
Last question, is chicory root fibre good or bad for a FODMAP diet?
I really don't know about that, and I think we'll probably ask our dietitian, and we'll get back to you on that.
Thank you. So thank you for everybody that asked the questions. If you've provided your name, we'll be able to answer any other questions after the webinar. If you'd like to book your consultation, please contact us on the number on your screen for 8 o'clock tonight or between 8 and 6 p.m. Monday to Friday. You'll receive a short survey, and we would be grateful if you could spare a few minutes to let us have your feedback on today's webinar. Our next webinar is on 30th of June with consultant gynecologists Rowan Connell and Anna Zacharian, who will be discussing the Mona Lisa touch and female health services, including HRT and menopause. So on behalf of Dr. Hanumanthiraya, myself and the team at Benenden Hospital, I'd like to say thank you very much for joining us today, and we look forward to you joining us again on another webinar very soon.